So you need to know about vertical gaze palsies and how a vertical gaze palsy can occur for either up gaze, looking up, or for down gaze, or for both. And that occurs at the level of the vertical gaze center. The vertical gaze center lives in the junction between the mesencephalon, this is the pons, this is the midbrain, and the thalamus. So at the thalamic mesencephalic junction is the connection between the supranuclear input and the nuclear input to look up and down. And as you know, those are mediated by the cranial nerve nuclei, and in the brainstem at the superior colliculus and inferior colliculus level, that is cranial nerve number 3 and cranial nerve number 4. So when you have the vertical gaze center, which lives right here at the thalamo-mesencephalic junction, it tells your eyes to look up and look down. For the up gaze, that fiber crosses in the posterior commissure, and that means a single lesion at the level of the dorsal midbrain can cause up gaze palsy. But for down gaze, it's a bilateral innervation, so it requires a bilateral lesion to cause a supranuclear down gaze palsy from the vertical gaze center. The vertical gaze center in humans is the rostral interstitial medial longitudinal fasciculus and the interstitial nucleus of Cajal. They live right here at the thalamo-mesencephalic junction. You have bilateral input for down gaze, but because of the crossing fiber in the posterior commissure at the level of the midbrain, you can have, this is a crossing fiber, you can have a single lesion at the level of the dorsal midbrain that produces an up gaze palsy. So one of the things to differentiate the supranuclear from the nuclear and infranuclear is the doll's head maneuver. So we can move the pupil's head up and down. And if the eyes move up and down, that means they can move. That is supranuclear. You can also make them close their eyes real tight. That's the Bell's phenomenon. The eyes will roll back in the head as a protective mechanism. That means the eye can move. These are two easy things to help us differentiate whether we're dealing with a nuclear lesion in the cranial nerve nuclei of 3 or 4, or a supranuclear problem at the level of the vertical gaze center, the pre-nuclear input. And that happens when you have a thalamo-mesencephalic infarct from basilar perforators that are penetrating into the brainstem in this location. And because the basilar artery also supplies the posterior cerebral arteries, you can get the weird combination of afferent and efferent. So you have both double vision and can't move my eyes, and blurry vision because you're cortically blind or you have a homonymous hemianopsia. Both of those implicate the same arterial distribution, the posterior cerebral artery and the vertebrobasilar artery is what's supplying those. And so basilar thrombosis or vertebral dissection can lead to both PCA infarction, lose your vision, and up gaze and down gaze problems from thalamo-mesencephalic junction at the vertical gaze center in the thalamo-mesencephalic junction. Both are PCA.